Welcome to the second episode with me and Dr. Angela Wright. If you listened to the first episode, we were talking about being hormonally sensitive, being neurodivergent, when you react to certain hormonal medications, whether it's HRT or hormonal contraception. We talked a lot about our own medical histories. And in this part of the conversation, we're going specifically into trauma-informed medical care, or basically why so much of the medical system is not trauma-informed, because it's not taught from the top down, and what Dr. Angela is doing to try and make a bit of a ripple of a change. And we'll also be talking at the end why we are both going to be putting together a workshop to help patients advocate for themselves in medical settings, particularly in gynecological settings. We haven't published the date of it yet, but I'll put the link to the waiting list in the show notes. I really hope you enjoy this episode. If you haven't listened to the first episode, do listen to the first episode, or don't. Do whatever you want to do. I hope that both of these episodes leave you feeling affirmed and seen, and I hope they help to heal a little part of you. If you have a long history of being fobbed off, gaslit, generally treated like shit by the medical system, and understandably, you developed a bit of trauma, a bit of a phobia, a bit of distrust around a lot of medical doctors, I feel very similar. So enjoy both episodes. Enjoy this episode as well. And I love how this is segueing. You've segued us into the second part. And I think with this, I'm probably going to divide this episode into two different episodes.
Long, isn't it?
It's going to get long because there's a lot here. This is on trauma-informed medical care. And, you know, it's what you just said about how the medical system is still very paternalistic, if that's the thing, where it's basically, I'm the doctor, I know best, I am the expert, and I'm the expert on you.
Yeah.
And how this transports, especially not just to medical care, but especially gynecological care and pelvic care. And there's a kind of outline for this, because one of the great symposiums I was at the SSM Congress was on working with sexual abuse survivors, and there was an amazing talk by a gynecologist on trauma-informed pelvic exams and pelvic care. And in many ways, for me as a sexologist who's done some trauma awareness training, it felt like a no-brainer what she was talking about. And yet it was very shocking where she said at the end of her talk, how many people here are medical professionals. And I think there were 4 in the whole of this auditorium. And how one of our colleagues, Silva, was talking about how it's still not baked into the medical system. So let's talk about trauma-informed pelvic exams. And I say what your take is, how you what problems you see and how you do them differently in your practice, and how you want more doctors to start doing it so that women and people with vulvas don't get traumatized.
Do you know, it feels like the way to start that is actually with an apology for the profession, because I think that actually I come from a profession where in my training, which was late 90s, I finished in 2002, we were still going up to women who were going to have gynecological surgery and saying, hi, I'm a medical student. Can I have consent to learn examination when you're under anaesthesia?
And at least they ask for consent.
At least we asked. Prior to that, you weren't asking, but also there's a power imbalance in asking. It's difficult to sit in a vulnerable position and say no to somebody. And, I had no concept that I might be asking people to give me permission to do something that they weren't there. They were not there to be able to control what I did to their bodies. It's a hell of an ask, really.
Yeah.
So I was sort of, that's how you're trained. And you're trained to ask consent and to be respectful. And that's something that probably wasn't there 50, 75 years ago. So you definitely do get trained into that. But what you're not really trained about is the trauma responses. So the awareness that somebody may default to fawn if somebody with perceived power asks them to do something, and actually they may not be in a position to give consent or set their boundaries out or stay fully present or whatever else. We're not really taught that. We're not taught that somebody may freeze during an examination because you may trigger them and they may be then somewhere else dissociated feeling, or worse, being re-traumatized with a reimagining of what's happening. None of that was in my training. And when I speak to colleagues, when I talk at a lot of places, I'll almost always put something in about how we examine, because we're not taught about that. So I don't think it's rocket science. I don't believe it's, well, lots of people don't know that what happened to them is trauma or is still affecting them. So I don't think it's on the patient to tell us that they think they've got a problem with this process. I think it's on us to approach everybody from the same position, which is assuming there may be something that might make this difficult. And I think it's mostly about creating a situation where it is explicitly discussed that you remain in control the whole way through the procedure, that I'm going to ask permission for every part of that procedure and keep checking in with you, explaining before I start what I'm going to do, and keep checking in with you, making sure you're present, you're there, and that the next thing I'm going to do is okay, and is the next thing okay. We talk about how it could be stopped if it's not, because sometimes people, the ability to verbalize will go offline. So if I'm not astute enough to notice that you've gone really silent and you're not answering, or you're particularly still, I'll try and connect with you, or I might ask you that you might raise a hand or something if you're finding it difficult, because verbalizing, finding the words may be difficult. And sometimes you need to do the examination on a different day in different circumstances with a different person present. So there's no one size fits all. For me, it's just about acknowledging this is really vulnerable. Like, if some people are fine with it, but actually I have smear tests, I have coils inserted, I still feel really exposed and vulnerable and disempowered during those procedures. It's an incredibly open position that we have to put ourselves into, with all the societal shit about what we look like and the shame lots of people carry about their bodies and their vulvas.
I mean, this is similar with me. Like, I've been in many nude situations in sex positive tantra spaces. I'm very comfortable being nude and showing my vulva. And I still find gynecological settings off-putting. Like, I do not have any sexual trauma or medical trauma, but apart from the ectopic pregnancy, but apart from that, I don't have any really, deep stuff like that. And it's not a nice feeling to be in a clinical setting where you're being asked to strip off and you're lying there on a bed, your legs wide open, being probed in a very intimate, sensitive part of your body that also for many women and people with vulvas has never looked at their own vulva properly before. So it adds to that. And so you're already going to be tense. You're already not going to be feeling relaxed, no matter how many times the doctor says, just relax. Okay. You're already going to be on edge. Your body is already going to be automatically slightly clenching. So it's going to already be there's more possibility for it to be slightly more painful.
And there's things, so I had a lady who was referred to me with a really complex, relatively recent trauma history, but also with potential gynecological issues. And the first thing I did in the first consultation was to reassure her I wasn't going to be examining her in that sense. I know it's not, we're not going to do that today. We won't do that till you're ready. I think on the third meeting, we did the examination, but we talked about how she would remain grounded through that process. So she brought with her something that had a smell from home. She, kept that with her when she was there. She had a hand just over her vulva so that she had that sense of ownership. And we talked about it the other week when I saw her. It was the first experience of maintaining her presence and her autonomy in a medical setting, because she'd had lots of intrusive examinations from people who didn't understand her history, who added names. You've got a difficult cervix, it's a difficult vagina, or and I was just like, oh God, people. And that's how I felt. I just kind of think, oh God, we don't go into this job to do harm. I don't think that many of my colleagues are meaning to do this. Not that that's an excuse. The onus is on us. But it's just not in the psyche to think in this way. And actually, if anything, you're taught to get in, get out, get what you need and do it quickly. And that's the best thing you can do for your patient, is be competent and fast.
This is what you told me. I remember.
Yeah. And it's and there is something in that. I had a coil change done that was ninja quick. It was brilliant. But, I'm an informed patient and I know what's happening during that procedure. But even I fawn. I do my best to make it as easy as possible for the person doing it. So I want to be a good girl. I want to be a good colleague.
The same, and like, I talk a lot about the fawn response to breaking out of people pleasing because it's my own fucking lived experience. And
Yeah.
again, I am, especially if I'm in, I live in Austria, there's the language barrier. Generally the doctors are English speaking, and still,
Mm,
I don't want to be the difficult British
mm,
patient who's
mm,
causing
mm,
problems.
mm,
Um, and like I told you when because about 2 months ago, I had a scan of my left fallopian tube because I had an ectopic pregnancy rupture back in November. I've only got one tube left, and I'm going to describe it briefly on the podcast here, because when I told you, it was almost like all the ways in which they basically did it wrong.
mm,
And I had it done at a private clinic, and the doctor was lovely. I want to say she was so lovely.
mm,
But I remember when I met you in February and I was saying, I want you to be honest with me, will this hurt? And you said it could hurt
mm,
because a hycracy scan or scan of the fallopian tube, they have to slightly open the cervix and put a catheter in, insert dye, and the dye will light up and see if the
mm,
fallopian tube is blocked. And so the first thing I did when I called the clinic, I said, what pain relief are you offering me? And I could hear them on the phone. Pain relief?
mm, mm,
What
mm,
pain relief? We did what?
mm.
Almost like I was speaking to them in a different language, and I was like, pain relief because you're going to be dilating my cervix, and yeah, that was really shocking for me. They said, well, we don't really have any pain relief on site. And by the way, this is a private IVF clinic,
Yeah,
so
yeah, yeah.
you think they
It's
have.
normal not to. It's not. It's normal to fit coils without it. It's normal to do loop excisions and so on. Under local, we do
Yeah,
hysteroscopies awake. I mean, and there's benefit in that for the patient if it's an informed choice, and if you're. I'm not saying that we should be sedated for everything. Actually, perhaps if we can support people to feel in control and safe and in charge of stopping, slowing, pacing, those things might be sufficient. But it's about choice. And I think what drives me mad is lack of choice and lack of personalization to the individual. I had
mm,
camera tests down into my stomach. So they go sort of past the tube round your throat and down. I mean, again, that, could be a
oh,
very triggering, but also
I
very
had
triggering
that.
thing for people with particular trauma and so on. I did not want to be asleep for that. It was important for me that I was awake and in charge and everything else. But the thing that I found the most difficult was the hand that they used to sort of hold me in place felt like I was being restrained, you know?
Yeah,
And there's not an awareness of that. And how would you feel most comfortable? And what do you need so that you feel you can? We just need to train it in. So I don't think there is a specific technique. I had to write a chapter in a book recently and I included this. And I was just like, the patient doesn't come in with a requirement to tell you about their shit that they carry. It's bad enough carrying the shit, let alone having to, tell everybody, be careful with me, be careful with me. Like, why would you don't want to
yeah,
have to do that to everybody?
yeah.
The clinician needs to be mindful that this remains the patient's body. The patient is a human being, not just a body part. And you remain in communication with them when you are lucky enough to be invited to examine them or be in their body.
Well, it's like why I think maybe the second time at some point, it was very early in my journey of having pelvic exams and having speculums, and it was a sexual health nurse. It was a nurse in the sexual health clinic in Eastbourne, and
Mm,
she was the first one to tell me I could ask to insert the speculum in myself,
mm, mm.
and I've been spreading that gospel ever
Yeah.
since.
I
And
send
it's
women home with them and say, just try it on your own first.
I know it can be very empowering
Mm,
actually. Um, And you're going back to that. So with this hycocele scan, the doctor was lovely. She let me insert my speculum myself, but she strapped my legs into the stirrups. And I do not have sexual trauma. I've never been assaulted. I do not have specific medical trauma, and I did not like that.
yeah, of
I
course.
did not like that my legs were strapped in, and I asked why they did that. And she said, "Oh, it makes you feel safe, makes you feel more held." I'm thinking,
No, it bloody
I don't
doesn't.
feel, I don't. I feel trapped. And again, she was a lovely doctor. It would have been a very different experience if it was a very brusque doctor who just rushed me through it. It would have been a horrible experience. She was lovely, and yet I still left that procedure feeling uncomfortable in the way that it was managed, because they also offered to give me sedation. I
Mm-hmm.
thought it was bizarre that it was an IVF clinic that does regular embryo transfers and high-accuracy scans, and they said they do not keep numbing gel, like cervical numbing gel on site. To me, that was very bizarre.
I mean, I
Yeah.
don't do hycosis. Sometimes there are procedures where you don't use specific lubes, or you've got to be careful about contaminating the process. So some of the topical things.
Mm.
Um, so specific things that you might use, some of them may not be desirable or preferable, but there is an overriding sense that we don't do this for gynae procedures because it is possible to open the cervix, and because at certain times in your cycle, women who have had a number of babies and perhaps have a more open cervix, and for some people it is possible to do these things without pain relief, and it's okay. It's genuine. There's such a variety of experiences when you
Yeah.
talk to people who've had coil insertions from it was the worst thing ever to totally fine.
Yeah.
And I
Same.
but I guess what's missing is it's a form of respect for autonomy. I think it's as simple as that. It's just, I don't know what's going to be okay with you, so I'm just not going to make an assumption. I'm going to check, and I guess that checking needs to go. Do you remember? Did you go to the lecture at the ESSM where they were talking about whether if you were an LGBTQ individual, whether you should have an LGBTQ therapist or whether any therapist?
No, no,
It was an
it's
interesting debate. It was
yeah.
like, am I, if I've had trauma, similar thing, am I better going to a clinician who's had some trauma because they get it? Or should it be that all of us make no bloody assumptions about anybody because we don't?
Mm,
And my view is we should just make no assumptions. All women, all vulva havers are not a homogenous group. There is
mm,
so much difference in every single person's values, lived experiences, goals, and I know that time's a big constraint for us, but there are some simple things that you can do that, you just ask, do you find examinations difficult? Is there anything that I can do that will make this process easier for you? Do you need anything to make this more comfortable for you? How are you going to tell me to stop if it's difficult? I'm going to keep asking you questions just to make sure that you're okay and to make sure that we're okay to proceed. You can stop at any point. We don't have to achieve this today. We can
mm.
give it a go and we can stop. Simple.
And this is what breaks my heart, and I guess breaks your heart as well, is that for clinicians, for whether it's a doctor, midwife, gynecologist, nurse, or any medical professional that is
Yeah,
dealing
anyone.
with your fanny,
Yeah. Or your
it's
breasts, or your arse, or any part of you,
or
because we
any
don't know where the problem's going to be. Yeah.
any professional that is dealing with your body. It's the we don't you don't have to make big adjustments to
Yes.
be more trauma informed. It does not have to take a load of extra training. It does not have to take that much more. It's what was it? I still remember a few years ago in Germany, I was at dinner with my husband and his friends, and I got chatting to a dentist. And this dentist, his specialty was working with people who had dental trauma.
Mm.
And we were talking about what he was describing, what he does as a dentist for people who are afraid of dentists. It actually was quite simple,
Yeah.
which is talking people through, telling them what you're going to do, asking for permission, giving options. For any clinician, especially listening to this, I don't know if they will, but it doesn't have to be complicated. It
No.
doesn't have to be involve lots of extra bells and whistles, extra insurance, extra CPD hours, not necessarily.
I think it's just about respect and power, and it's about recognizing the inherent likelihood that there's a power imbalance in the room. It's not always there, but we're in a position of privilege, and unless we name it, even the privilege of the knowledge, even the privilege of knowing what the procedure is like, and all of that, it's just acknowledging that and being explicit that you have an intention to keep the person in control, to make
Yeah.
the person the center. And I don't think there's a lot. You find your words, you practice your words, and then it's simple. And it will reduce complaints and it improves rapport and blah, blah, blah.
It does.
Simple.
It will reduce. I mean, it's also that we know, if I just know anecdotally, and I'm sure there's stats behind it, the amount of women and vulva havers don't get gynecological care, that don't go for a smear
Yeah,
test,
because of
that
history.
don't, because of their history. And so in many ways, there is a very literal medical need there. I know that in the medical world, there's the talk of, is it non-compliance, but factors
Mm,
that mean a patient will not
that's a
engage in
shit
medical care.
term. But isn't that awful?
I
You are
know.
not complying. Why?
Comply.
Why? Why? No, why are you not complying? What am I missing that's the reason why you're not complying?
I know.
And the other thing I see a lot of, I do a lot of work with people post cancer, and inherent in that process is quite a lot of medical trauma, or trauma that ends up living in the body, in terms of the existential threat of something can happen in me that I didn't notice that becomes life threatening. A little bit like when you talk about the ectopic and so on, it's that sense that your body can misbehave, do something without your awareness that can be
Oh
so
gosh.
threatening.
There is still a lot that I carry here. Like, as we are in this whole process of trying to bring a baby into the world, it's the new level of hypervigilance I now
Yeah,
have.
yeah,
Like,
exactly.
are you going to behave? Left tube.
Yeah, yeah.
Are you, it's yeah, but carry on.
No, I know that that's exactly it. And as I said, it's all functional. It's all logical. That's not a bonkers reaction. That is a completely rational readjustment of your worldview based on what's happened. And during a cancer treatment process, the way that treatment often happens, particularly if it's breast or pelvic or gynecological or penile or testicular, if it's part of you that is usually associated with you're expressing your sexuality, and
Mm.
then we do all this imprinting and positioning of bodies and intrusion and showing, and just all of that often leads to those things being the bigger part of what's going on when you don't really want to return to sex or intimacy afterwards. Some of it's to do with hormonal changes and surgery and everything else, but the bigger thing that I hear when I do the work that I do is the loss of autonomy, the loss of safety, the loss of trust, the loss of expectation of pleasure within body. And unless we process and hear that, that hypervigilance doesn't come down. I know you know that, but it's like your immediate reaction is to become super careful, super aware.
Yeah.
If you follow that through, there's another place where you perhaps rebalance that. But people they get stuck and nobody talks to them about it, and it's another loss at the end of the process. And a
Yeah.
trauma informed process, which recognizes that every time somebody does a gynae exam after a gynae cancer, A, it's intrusive, B, they're terrified of what you're going to find in there, C, it might be painful, D, it's disempowering. Somebody goes at that differently and more gently.
Yeah. And
It,
it reminds me of also that, add on to that, there's all of this cultural, not just cultural, I say emotional baggage
yeah.
around vulvas, around penises, around our genitals. Like there's a baseline cultural, I say, I'm sure there's a very intelligent way of saying this. It doesn't matter what culture you come from, every culture's got different levels of it. But there's a baseline that we all have of ick and aversion around
Mm-hmm.
fannies, vulvas, around penises. There's already that loadedness around our genitals.
Yeah, yeah.
And then add on top everything else. This is why in my client work, depending on where we're at, sometimes if I work with them one to one, we'll because it's on Zoom, you can turn the camera off. We'll do a session where they look at their vulva with
Mm-hmm.
me on the other side of the camera, so I don't see
Yeah,
anything.
yeah, yeah.
But also I have other colleagues that, and I'd love to do this in person at some point, where it's a workshop where you're in person and you're
Mm-hmm.
looking at your vulva with other people around you. And I've done this myself, and it's been so healing. It
Mm-hmm.
sounds so simple to look at your vulva or your penis in a mirror and other people are around you, and to have it witnessed and just it's seen as another part of your body is
Yeah.
so healing.
Well, the shame that so many of us carry around body full stop, and the weight of all of that, and the sense that you're not okay to be here if you're not bringing something perfect, whatever
Mm.
that current definition of perfect is, and the impossibility of that. There's a trend at the moment for women, and I was thinking about this morning. There's a trend at the moment for women who have topical estrogens, so the creams and the gels that you can apply, or you should be applying to your vulva and your vagina, to use it on their faces, because it's become there's a thing about the fact that it may be anti-aging, and there's possibly some tiny bit of evidence in there, but there's also lots of caveats and concerns around pigmentation and absorption and yada yada. But I was sat there pondering that this morning, thinking, what does it mean? People must only get one tube a month. And are they choosing not to stick it where it will do one bit of good? You know where I'm going with this. So that we can look better to the outside world, whilst at the same time removing potential for joy and pleasure and comfort. And there's something, I thought there's a blog post in there you need to write, Angela. There's something you need to.
Sacrificing your face for your fanny, or sacrificing
Yeah.
your fanny for your face. It's that, there's
To be wanted, to have somebody desire you potentially is what it really comes to. Desire yourself, I think it often is with a lot of the people that I work with. There's a loss of finding themselves sexy as they age and change. But yeah, the whole bloody lot is bonkers. I just want to live in a world that's more allowing, of difference, of change, of individual nuance and quirk, and and just to be within a system, or maybe to be part of making a system aware of how it isn't doing that at the moment, and maybe it's good for all of us if we reconsider how we're doing stuff.
Oh my god, I feel like this is a useful maybe ending point for now. So two more things. So first of all, as we round off this particular podcast chat, I've got a question here. What are your top tips for women navigating menopause or hormonal changes, and they feel they've been dismissed or misunderstood by their doctor and they need that care?
That's a really good question. I mean, it's about arming yourself with information, but good quality information. It's a really mixed bag out there. There's some proper bullshit doing the rounds. And then at the other side, some of the information that comes out from reputable agencies can be very tied to evidence, so it can be quite rigid. So perhaps it's just having a critical appraisal of the information you've had and forming your own opinion of it. But the biggest thing is finding a practitioner, and I'm not alone in this. It's not the answer to that. It's not come to me. There's a lot of people that want to do a good job of doing this work. There's a load of passionate colleagues that I've got that are keen to listen. So you just need to choose somebody who's got an awareness. There's quite a few of us that have got an awareness of hormone sensitivity. Go to someone who's an accredited specialist. In the UK, there's a list of British Menopause Society accredited specialists, so at least they've hit a certain level. There is something in looking at reviews, I think, because you'll get some sense of generally how someone's been seen.
If you can send me a link to that hormonal, the menopause accredited?
Yeah, I can do that. It's part of your links. There are other ways of training, but in the UK, usually, to call yourself a menopause specialist, you should be British Menopause Society accredited. And that means you've got to hit certain levels of staying up to date and attending training and working within certain frameworks. But there's also something about for me, I think there's a balance of receiving information and integrating it, so letting stuff in from the outside, but not losing your voice in all of it. And I think if you think you're not being listened to, if you're experiencing a side effect and you're damn sure that it's different when you're on the half of the month with progesterone than you are when you're not. And that's the classic thing, is that you have a good and a bad half of the month if you're on sequential HRT. Keep a cycle diary so you can see it through the wilderness, because there's all sorts of shit that happens in people's lives that clouds patterns. So a cycle diary is really useful. And if at first the person you're talking to doesn't listen to you, I'm sorry you have to find somebody else, but go and find somebody else.
Yeah. And something I've learned from, if you can ask for recommendations, like I was in a really good business networking group, and when I lived in Brighton, called Co-Women, and there was a lot of chat about menopause in there where people were asking for recommendations. Depending on what communities you have access to, there are Facebook groups. Just ask. Even if you feel awkward about it, I guarantee by you posting that question, there will be many other women, many other people with the same question who want If
you can't pay, because I think that the problem is it's a lot easier if you can pay, right? And you just go, okay, I can afford to do this.
This is the thing, you're probably going to have to go private to find a good one.
You can do, there's lots of NHS, most of the menopause specialists that I know stay in the NHS or have an NHS clinic, and they're also listed on the same website that I was telling you about. But even within communities, talk to the other women at the school gates, talk to the
Yeah.
people down the gym who are roughly in the same age bracket as you, because the good doctors get known very quickly, and there's
Oh,
usually
yeah.
a doctor who's good on women's stuff. So find that out and track them down.
And be courageous about it. Even if you feel uncomfortable about it, know that by you being courageous and asking, you're actually also going to be giving permission to everybody else.
Yeah.
Like, this is a slightly different thing, but I remember chatting to some women in Vienna, I think a year ago, and I just brazenly said, "Oh, I saw the psychiatrist." And then a woman came up to me afterwards and was asking for my mental health experiences because of her own mental health.
Yeah.
So when you are vocalizing and asking for help with a menopause specialist or for anything else, I guarantee and I bet my entire Earl Grey collection, you'll be giving somebody else permission to do the same. So you're actually doing a community service in a way.
That is my thing about, I often say to patients, I live in a really beautiful area, and I often say, if I hadn't have had this experience, I can understand why people find it hard to understand what it's like to have a hormonal mood change, because it is so dramatic. I walked around one day, I have a dog walk that I do, and on one day I was questioning my job, my relationship, whether I was good for my family, everything. I was like, it's all shit, I need to go away. This is, everything is really difficult. Literally the next day I was walking the same path and going, oh my God, look at the birds singing. Aren't I lucky? Look at the beautiful trees. It's so gorgeous. And that's the feature of hormonal mood changes. It is a snap and you have depression and anxiety or whatever it is that's going on, and then snap, you're out of it again. Certainly for PMS, PMDD, there's something called premenstrual exacerbation, which is where there's a level of something all month and it steps up.
Yeah.
But
And this
that
is, yeah.
is, it's weird, isn't it? Like, if you hadn't got the lived experience of it, it would be very difficult to look at somebody and understand why they might feel so very different in the same context from one day to the next. So that's where having a tribe is really useful. If you know that there's a group of people, if you connect to IAPMD, or in England it's NAPS for the guidelines, so that you can go to your clinician and say, I've had this experience. Here's this reputable set of guidelines that speak to my experience. I know you may not have had much training in this, and that's okay, but will you help me? Can we figure this out?
Yeah.
Give them space to be unknowledgeable.
Yeah.
That's often useful as well.
Yeah. Thank you. This has been such
We could go
what's it?
forever, couldn't we?
We could, like, this is why, and this is also why it's a soft launch, a soft drop. So we still need to create this, but
Yeah, get
Dr.
our asses
Ange,
in gear.
I know we're going to be creating a workshop specifically, first of all, aimed at women and vulva health, so aimed at patients, which will be on advocating for yourself and taking care of yourself within a pelvic exam.
Okay.
So I'll probably put a link with a little wait list or something because we need to organize it. But it's something that we're going to be doing, and it will be online to begin with. And it's for you if you want to have specific knowledge and specific tools and specific action plans of how you can advocate for yourself in a medical setting. Before anyone says, I know it's shit, we want the system to change, okay? We really want the whole system to change, but this is hopefully a workshop where you, as a patient, as an advocate, will have more tools for when you're going next week. Because we can't change the system, unfortunately, by next week. Wish we could, but we can't. So this is one small thing. We do want to, we'll see where this workshop goes as to whether we can deliver this also to medical professionals. But if this is a workshop that you would love to attend, I'll create a waitlist link below and I will let everybody know when it's ready. And so will Angela, and we will create it.
Create.
So any final words or how people can contact you and work with you, Angela?
Yeah, I mean, this is the bit I'm always dreadful at. So,
Elevator pitch.
yeah, there's always that kind of thing that in an ideal world there wouldn't be a paywall, and a lot of what you would do would be easy access. So I do that. I do have NHS. If you're in the UK, if you're in East Yorkshire, Hull area, or North Yorks, they're places that I'm accessible on the NHS. If you want to see me online, you can do that through Spice to Pair Health, which is spicepairhealth.co.uk. And I do face-to-face work through Miss Claire Mellon and Associates, and I do online with them, but it's nice to have a face-to-face setting. So that's at the Portland in London, and that's at Wilmslow Hospital in Cheshire. And I do a lot of free access stuff. So I work a lot with Maggie's. I do intimacy workshops with Target Ovarian, Breast Cancer Now, done some bits of Action Bladders. There's quite a lot of free info and resources online, or you can attend these things free as well. So there's lots of ways to find me.
And I'll put all the links in the show notes so you can work with Angela, Dr. Angela. Angela.
A really bad kind of, this morning.
Dr. Wright.
Yeah, no, Angela's good.
Do you know a really funny thing here in it's a very uniquely Austrian thing. So my husband has a PhD, so he is Dr. Schnabel. In Austria, not Germany, in Austria, I can call myself Frau Dr. Schnabel, which is hilarious. I never do.
Bizarre. I'm going for, I'm still looking at masters. In my head, I want to be professor, doctor. That's where I'm going. I want a PhD. I want all of it.
Yeah, I mean, I would love that too. I don't know if it's ever going to happen, but it's, I think people have, I've been called Frau Dr. Schnabel once, which I find really strange.
It sounds amazing. It feels like you should be some kind of like superhero with that name.
I know, like I've earned a doctorate without actually having done a doctorate. Unfortunately, it's very sexist. It doesn't work the other way. So if I had a PhD and my husband didn't, but there we go. Anyway, we're going to stop now, and do tell us how you found this episode. Give us some feedback. Contact me, contact Angela, and that's it for now. Bye, everyone.
Bye.